You all. I'd like to welcome our session speakers to the panel discussion. So we'll see everybody together. And as a reminder, I'd like to encourage our audience to submit questions and comments via the chat box located below the webcast video. We appreciate anyone's questions. And I want to start by following up on Monica's presentation with the other three panelists in terms of focusing on community engagement. So Chow, you had talked about co-creation, and UTB, you had talked about the different layers of from risk all the way up to access and so forth. And Adrian, you had talked about cultural competency and the setting and conditions that are part of the Navajo Nation and the entire Indian Health Services. So I think you each bring a level of activity and nuance in ways that you might think about community engagement for improving diagnosis in the communities you interact with. So I wanted to just do a quick round robin with the three of you to add to what Monica said in terms of maybe what, one thing you think would be pretty cutting edge based on what you've seen in the pandemic to changing something about the environment or the conditions or the practices in a way with community engagement and focusing in on how to engage in improving diagnosis based on what's happened in the pandemic. And maybe I could circle back and start with you, UDB, because we haven't heard from you for a little while.
Sure, that sounds good. So yeah, it's an interesting question. I think one tool that we often think about broadly in the health system is technology and community. And I think bridging those two to improve diagnostics can be really useful. We started the pandemic around rather the same time with the conversation around inequities in pulse oximetry. So how do we assess oxygen levels of individuals who are darker, more melanated compared to lighter skinned individuals, seeing some of the inequities there. And I think that's just one example of how we can actually improve technology to advance equitable treatment and access to care. But of course, there's other broad technology opportunities, whether it's mobile apps, wearable devices. We're seeing these really extend along the way. And again, I think many have already mentioned access to testing. How do we kind of innovate around access to testing so that, and technology around testing so that communities are aware of what the resources are available, and thinking about the cost opportunities for communities to be able to engage in those technologies. So I think there's a great opportunity to be more innovative and equitable around technology to improve care, especially in the pandemic, and really leveraging the community expertise there as well.
Thank you. It's really interesting. Chow, maybe you could follow up next. Any of your thoughts?
I just wanted to really highlight the key role of working with community-based partners. They were really a tremendous part of our SEAL award. They know the pulse of the community. They have an established history of trust. So for example, the Arthur Ashe Institute for Urban Health, who we work with, sort of a large Afro-Caribbean, African-American population throughout New York City. They were able to reach out through their barbershop and beauty salon network and to create palm cards that made sense and be able to help distill messages that individuals would be able to give back to their clients and help to engage individuals around vaccine, around COVID-19. We also worked with the Make the Road New York, who worked with a large undocumented immigrant population, both Asian and Latinx communities, and they were able to use their phone banks, had already had an established history of reaching limited English proficient communities to really be able to tap into that grassroots engagement. So they were really key in terms of understanding the pulse of what the community, understanding the social determinants, helping us to do persistent, repeated engagement. I think that was very key. It's not a one-off or two encounters. It was really repeated encounters using trusted messengers, working, in multiple ways and sharing information that really resonated. The co-creation process engaged our community organizations as well as community health workers to make sure that the messages that we were imparting really resonated and had value, and messages related to also not only around risk mitigation, but also thinking about well-being and wellness. Mental health and stressors, other stressors were a huge side impact of the pandemic and really impacted many communities in terms of thinking about what does it mean to be positive with COVID-19 and what does that mean in terms of protecting my family and how do I shelter in place when we're living in a very tight area. And so it really, there was just, community engagement was a central part of all these efforts.
Let's follow up and ask, do you think that there's real risks in terms of maintaining that sort of persistent community engagement after the pandemic in ways that can, do you see risks in terms of having inequities widen again after the pandemic because maybe attention will lessen? And do you see ways to mitigate those risks? How do you look at that from where you sit?
The repeated engagement is really key to maintaining rapport and building trust. It's not enough to share information through pamphlets or flyers or social media. They need to know that there are individuals who are like them, who speak the same language, who have shared characteristics, and who are also going through the same similar context. We did have to think through for our SEAL Award, for example, making sure that there was enough masks and other protections. But we are able to help work with our community organizations to do virtual delivery and to use the phone banks, the text banks that they have to keep sending them messages. So in some ways, yes, there are some risks. I mean, certainly many of our partners in the last month were impacted by COVID infection in our own households and among staff, and that was across the board in New York City. But I think that it is a key part of ensuring that we can maintain, establish that engagement. One thing that we were very careful about was to make sure that there was not a sense of helicopter community engagement, that we were just coming in at this moment. So the repeated engagement is key.
Yeah, being able to maintain that and those lessons learned afterwards seems like it'll be pretty important going forward. Adrian, what are your thoughts in terms of maximizing or benefiting from community engagement in the communities you interact with around diagnosis as a family medicine doctor? We also have let me just add to this. We have a question from our audience about examples of diagnostics contributing to racial disparities in mortality and hospitalization. So in terms of working with the communities you work with and thinking about any examples of the diagnostic practices, the diagnostic technologies contributing to the disparities that you see in the communities you work with in terms of mortality and hospitalizations. What are your thoughts about that?
Well, I think one of the issues that we ran into was the demarcation because one of our facilities is off the reservation. And so the counts would go to the state of New Mexico rather than, because we were a border community. And so the reservation is just not too far away. And so they wouldn't sometimes count appropriately as to if it was an Indigenous person versus a non-Indigenous person. So that was, and probably had some under numbers that didn't reflect that they were Indigenous people that were positive. So some of the rates could be higher. And we also don't, like in the urban areas, as far as they may not be classified appropriately. A lot of times we find that they're classified under Hispanic classification.
Yeah, that classification problem and masking inequities that you brought up, Chow, it's interesting to hear your experience there too, Adrian. UDB, in terms of like the data situation, the data infrastructure, I want to start with you, and then Monica, I want to go to you because we're hearing about these data problems and masking disparities and how that, of course, is going to be a contributor to disparities being maintained and not well understood. What are some of the areas that you see as most important to address from a data infrastructure, from a missing data perspective, from an ability to disaggregate perspective? Having listened to a couple of your other panelists and just what you know about the area, how are you thinking about concerns related to what we don't know and what we aren't collecting and how we aren't using what we collect, or any of that, the whole stream from start to finish of data? So maybe you first and then Monica.
Sure, absolutely. It's such an important question. And again, this is not new. It's came up a lot, and the pandemic, like many things, exposed us to the challenges around data collection. But we have had issues and conversations about this for over a decade now. You know, the first output of the Affordable Care Act suggested that federal health systems collect and report race, ethnicity, and language data. And that was back in 2010. And here we are over a decade later, still having very similar conversations around not just accuracy, but as was mentioned by my colleagues, the disaggregated data so that individuals who check off other aren't lumped into a certain group, and we're missing out on the disparities that again we've seen throughout our various racial and ethnic minority populations. So appreciating that this is not a new conversation, that we have tools that have been outlined and advised, and we just need to do this work. And then on the other side, whether it's by public agencies who are reporting these data and using these data to inform policy, or it's by researchers like myself who are ultimately reporting the data to hopefully be able to change clinical practice, I think really being thoughtful about how those data are being collected, who is identifying as African-American or Hispanic or Native American, et cetera, and making sure that there's uniformity across the board so that from the medical journals to the classrooms that we teach our students, there's some consistency there. And lastly, I think, and Dr. Hooper mentioned this in her remarks, not using race as a marker of poor health, and not saying that because we see these high rates of XYZ condition in Black individuals, there's something wrong with Black people. I think a lot of our remarks today have expressed that really it is the social factors that are driving health. So there shouldn't be a fear to collect this information and worry that, oh, I want to be colorblind and I don't see color. But there also needs to be real important clarity around how and why we're collecting this information, not to biologize sickness or disease, but really to help ensure that communities are receiving the care that they need.
Glad you're underscoring that. Monica, do you have some thoughts to add in terms of the data infrastructure and data streams and what's really needed, what's missing, and where the investments need to go, and why that will matter for being able to end up with less inequities and especially from that central point of what happens diagnostically and testing abilities?
Sure. I think I'll add that it's really important that data are collected and also collected in the same way using standardized measures, because then without that, it makes it very difficult to conduct cross-study analyses, meta-analyses, and to really understand the overall impact. So NIH is really, and NIMHD has led a lot of the efforts to facilitate the collection of common data elements for social determinants of health and also demographics, so that to encourage researchers to collect these data in the same way. There are also national resources and databases where we are encouraging the sharing of data so that we have larger sample sizes to be able to facilitate things like disaggregation and to be able to answer questions that we otherwise would not be able to answer. So an example is in our RADx-UP initiative, the teams are submitting common data elements. So that's what will allow us to have a cohort that's really unlike any other with the kind of information we have in such a diverse sample. So the standardized collection and the sharing of data is really critical there.
Thank you. I want to pivot a little bit to another area that was raised in actually your presentation also, Chow, about clinical trials, participation, recruitment, and equity issues there, not having the data from the perspective of what we can know from an evidentiary basis, because people weren't included in the trial who were under different conditions, whether it's historically affected over generations and generations, or in a more proximal way in terms of access to care impediments. What I'd like to throw this open to anybody who feels like they have something that they'd like to make sure is understood about how we could have better equity in the collection of information about people through clinical trials. What are some of the barriers? What do we have to get over that relates, especially if there's a trial that's related to diagnostics, since we're in an improving diagnosis workshop today?
I don't know if we'll all jump at once, so I can start and of course pass on to my amazing colleagues. So two things here is really ensuring that equitable representation within these trials and addressing, because our focus is on these social factors, some of the social barriers. I think financial barriers to access to clinical trials is key. And I know that there are some insurance policies and federal level policies working there to ensure that patients can literally be able to enroll in a study and not have to worry about some of these challenges. And so again, addressing the equitable representation, I think, is key. And I think even further upstream, we have to address the scientists in the room. This is an incredible panel of diverse scientists. This is not what the various funding agencies look like. Data after data suggests, whether you're in the VA or you're in the NIH, that the individuals who are represented in funding do not look like the population. And so I don't think that the efforts, the motivation to study these inequities have necessarily been there over the last several decades. And so I'm hopeful that as we see more funding of underrepresented in medicine scientists, we'll ultimately be able to see more of a motivation to really equitabilize our clinical trials as well.
Like the word equitabilize.
Big word for sure.
Does anybody else want to jump in on the clinical trials piece?
Yes, I just wanted to note that, many of the clinical trial sites are within major academic medical centers because of the resources and the expertise, and I think that's right. But if we really want to think about increasing representation and diversity of that representation, and particularly, attract individuals and communities who are much more socially disadvantaged, who may have high comorbidities, there must be some level of acceptance of the messiness of that data in terms of the comorbid conditions, but also to think about a new paradigm where we create place-based opportunities for clinical trials participation in medically underserved areas, or build the infrastructure within safety net systems or federally qualified health centers that may be in those same neighborhoods who are serving those diverse populations to actually do some of the clinical trials work. It's an inconvenient and too much of a strain for many communities to have to travel long distances to participate in a major clinical trial at an academic site. If you don't, and not to think about the social determinants of health that impacts their ability to participate. So I think that thinking about creative or new paradigms of engaging and where we do clinical trials, having it centered in communities who may need those trials in a much more critical way, so that we can effectively reduce the experience of treatment-related disparities as well as diagnostic disparities. I think that would be key, to think outside the box.
I was just thinking, great to get the outside the box thinking. We're tracking there. Let me now ask from our audience. Don Harrison's asked, and I'm going to start with you, Adrienne, and then move to you, Monica. Do you feel that the gap of the healthcare inequity for minorities has decreased regarding COVID-19 from where we were at the beginning of the pandemic to where we are currently? So I know I'm starting with you, Adrienne, because you showed the data that December looks better for hospitalizations and mortality. Do you believe that data for Indigenous populations? Do you think that the disparity gap has decreased? Why do you think it's decreased? Any comments on that part that Don has raised for us?
Well, I think it's probably decreased due to the vaccination, our higher rates of vaccination. Does the disparities gap lessen? No, because you need resources, you need facilities, you need staff, and you need equipment. And without getting what we need, those disparities will continue.
Thank you. Monica, do you have some thoughts about this question?
Sure. I think when you look over time, the numbers kind of ebb and flow a little bit, but overall, we've still seen disparities. I think they're, depending on when you look and which population you're looking at, and you look at CDC data, you'll see some narrowing, But again, that is varied across geographic locations. And when you look more locally, and in addition, I think with vaccinations, we were pretty pleased with Kaiser Family Foundation data showing, that there was a narrowing in vaccination uptake. But then now we're seeing disparities by race, ethnicity, socioeconomic status, education in boosters. So, and among children. So there are some areas when you talk about disparities, it's really broad, but it really depends on which outcome you're looking at. And sometimes we see things looking better, and it depends on the population, the time, and the outcome.
Right. Well put. Last question for our panel, and if you could each just give, your sort of 30-second thumbnail of what you think might be most important. I want to talk about technologies, new technologies, and innovative strategies that have flourished during the COVID-19 pandemic. So some might think about telemedicine. I'm sure there's a lot that you've seen on the ground or you're aware of besides that. So are there new technologies? Are there innovative strategies that have been flourishing that could be used to improve equity and reduce disparities in diagnosis of other conditions after we come out of the pandemic, or people who have continued effects from COVID and having those diagnosed properly? Do you see some new technologies and innovative strategies that you think are going to be particularly well positioned to reduce inequities as we go forward? Of course, with the caveat of understanding that there are a myriad of other challenges in the space of reducing inequities. And let me go in the order that you all spoke in. So just so maybe you can start, if you don't mind me asking you first.
Sure. Yeah. Sure, I'm happy to start. I think a lot of us are still worried that if we do not really focus our attention right now on these health inequities, that we're going to see these health disparities play out beyond the pandemic. But really, I think some of the motivation and hope that I have is how quickly we're able to ramp up some of these new efforts to address the pandemic. Again, you mentioned telemedicine. I think that it was literally days after this was declared a global pandemic that we were shifting our clinics to be virtual only, to be able to engage with our patients. Sadly, we have seen, as I mentioned during my formal remarks, that resulted in some missed care. But I think if we are able to really expand on those efforts, and again, that goes beyond just health systems improving their apps, but increasing broadband, ensuring that the rural communities and my colleagues who are working in Indian Health Services all have that access, I think that then we'll be able to truly engage virtually with all of our patients.
Like a quick radio program, 10 seconds for each person left. So
definitely telemedicine is the future forward for many in terms of thinking about care, but many safety net systems did not do so well with telemedicine, in part because it was much harder for their patients to be able to access their providers. And so I think that there are a number of issues with respect to ensuring that they have that kind of accessibility and capacity, both from the safety net system, but also from the patients that are being served by these providers, if we're thinking about reducing inequities. And then just even from the experience with respect to access to testing resources the last month, many low-income communities may not have that kind of access. They had difficulties within their own neighborhoods. And then to think about the emerging technologies that might be available, it's probably going to be much more available to more affluent communities or accessible.
Great. Adrienne and Monica, it looks like we're actually out of time. I'm so sorry. Throw yours into the chat box. We're supposed to have a break, and I'm sure you all want the break and everybody wants the break. I want to thank you all for just all of your insights. There's a lot of work to be done, but I feel hopeful with everybody who is in this panel sharing their thoughts and so generously with the group. So thank you for your time, effort, and continued work in this area.